Most people with knee arthritis do not know they have it. Not because the signs are absent. Not because the condition is silent in the early stages. But because the 5 most common signs of knee arthritis are so easy to rationalize, to normalize, to explain away with the ordinary logic of aging, that millions of adults are walking around with early to moderate knee osteoarthritis that could be managed far more effectively if it were recognized and addressed now, rather than years from now, and the structural changes are more advanced and the treatment options are more limited. The morning stiffness that goes away after you get moving, many people assume that is just what getting older feels like. The ache that settles into the knee after a long day on your feet, normal tiredness, the sound the knee makes when you go up the stairs, that crackling, crunching sound that you have quietly started to dread, just joints being joints. The knee that has begun to look slightly different from the other ones, slightly puffier, slightly less defined around the kneecap, probably nothing serious. The sense that going downstairs has become harder and more uncertain than going up, weakness, age, something to manage. Every one of these normalizations is wrong, and every one of them represents a missed opportunity for the earlier intervention that the research consistently shows produces better long-term outcomes than the later intervention that follows the recognition of how significant the joint changes have become. Today I am going to take each of the 5 most common signs of knee arthritis and give you what the normalizations deny you, the specific biological explanation of what is actually happening inside the knee joint when that sign is present, what stage of the disease process each sign typically represents, and what the research says about the appropriate response when you recognize each one. This is not a video designed to frighten you. Knee arthritis is manageable more effectively, more comprehensively, and with better long-term outcomes than most people realize. But the management depends on the recognition, and the recognition starts with understanding what your knee is actually telling you. Before we go any further, subscribe to this channel right now if you want evidence-based health guidance specifically designed for adults managing or trying to prevent knee arthritis. We create this content specifically because understanding your condition is the first step toward managing it effectively. Hit subscribe. Knee osteoarthritis is a disease of the entire joint organ. The articular cartilage, the smooth, hyaline cartilage that covers the ends of the femur, tibia and patella thins, softens, and develops surface irregularities as the disease progresses. But simultaneously, the subchondral bone beneath the cartilage undergoes changes, increasing in density in some areas and developing cysts and bone spurs in others. The synovial membrane, the joint lining that produces the lubricating synovial fluid, becomes inflamed, producing the synovitis that is increasingly recognized as a primary driver of both symptoms and cartilage damage in osteoarthritis. The periarticular muscles weaken in response to pain-induced inhibition of muscle activation, and the joint capsule and periarticular soft tissues tighten and restrict the full range of motion that a healthy knee can achieve. Each of the 5 most common signs reflects one or more of these biological changes. The first and most common sign of knee arthritis is morning stiffness, the characteristic difficulty and discomfort in moving the knee that is present upon waking, and that typically improves within 30 minutes of getting up and moving. Morning stiffness in knee osteoarthritis is produced by 2 biological mechanisms that accumulate during the overnight rest period. The first is the settling of inflammatory exudate, the protein-rich fluid produced by the inflamed synovial membrane, into the joint space during the hours of non-movement during sleep. This inflammatory fluid increases the viscosity of the joint environment and requires movement-induced fluid circulation to resolve. The second mechanism is the overnight accumulation of the inflammatory cytokines interleukin-1 beta, tumor necrosis factor alpha, and interleukin-6, whose production by the activated synovial membrane follows a circadian pattern that peaks during the early morning hours, as we have described throughout this arthritis series. The morning stiffness of osteoarthritis has a specific diagnostic characteristic that distinguishes it from the morning stiffness of rheumatoid arthritis: its duration. Osteoarthritis morning stiffness typically resolves within 30 minutes of activity. Rheumatoid arthritis morning stiffness typically persists for more than 30 minutes, often for an hour or more, reflecting the more severe and more sustained inflammatory state of the synovial membrane. In rheumatoid disease, this 30-minute threshold is one of the most clinically useful diagnostic distinctions available to the physician taking a patient history. The second most common sign of knee arthritis is pain with specific activities, the characteristic pattern of pain produced by certain movements or demands on the knee that is absent or minimal during rest or simple walking. The specific activity patterns most diagnostic for knee osteoarthritis are pain going downstairs more than going up, pain when rising from a chair after prolonged sitting, pain when squatting or kneeling, and pain after prolonged walking or standing that recovers with rest. Each pattern reflects a specific biomechanical feature of knee osteoarthritis pathology. Pain going downstairs more than up reflects the patellofemoral joint loading pattern. Going downstairs produces patellofemoral joint contact forces of approximately 3.5 times body weight, compared to 1.5 times body weight going up, and the patellofemoral joint is among the earliest compartments to show osteoarthritis changes in many patients. Pain on rising from prolonged sitting reflects the stiffening of the joint that occurs when it is held in a fixed position for extended periods. Pain with squatting and kneeling reflects the highest load positions of the knee joint, where tibiofemoral contact forces approach 4 to 7 times body weight that damaged cartilage is least able to tolerate. The third most common sign of knee arthritis is crepitus, the crackling, grinding, clicking, or grating sound and sensation that occurs with knee movement, particularly on the stairs, when getting up from a chair, or when bending and straightening the knee. Crepitus in knee osteoarthritis is produced by two distinct mechanisms. The first is the surface irregularity of the cartilage, when the smooth articular surface has developed the fibrillation and pitting of early osteoarthritis. The roughened surfaces produce the crackling sensation conducted through the joint tissues and often audible. The second mechanism is the presence of gas bubbles in the synovial fluid that are compressed and released as the joint moves through its range. Research published in the journal Arthritis Care and research documented that the presence of crepitus in the knee, specifically crepitus that is painful or that has changed in character recently, is a meaningful clinical predictor of knee osteoarthritis, and a sign associated with worse radiographic and symptomatic outcomes over follow-up. Before we continue with the fourth and fifth signs, here is your pause. Of the 3 signs we have discussed so far, morning stiffness, activity-related pain, and crepitus, which ones have you been normalizing or dismissing rather than recognizing as signs of a condition that deserves attention? Drop a comment below right now and tell us. Knowing where this community stands helps us understand what information most needs to be communicated. We read every comment. The fourth most common sign of knee arthritis is swelling, the visible or palpable enlargement of the knee joint that represents the accumulation of excess synovial fluid, joint effusion produced by the inflamed synovial membrane in response to the joint pathology of osteoarthritis. The healthy knee produces a small amount of synovial fluid that lubricates and nourishes the joint, normally only a fraction of a milliliter, produced and reabsorbed in dynamic balance. In osteoarthritis, the activated synovial membrane produces excess fluid that accumulates in the joint space and the suprapatellar pouch above the kneecap, producing the fullness, puffiness, and loss of the normal bony definition around the kneecap that patients notice when they compare their knee to their other knee. Joint effusion in knee osteoarthritis has direct mechanical and biological consequences. The excess fluid distends the joint capsule, producing deep pressure-like discomfort that is different from mechanical cartilage overload pain, and the excess synovial fluid contains higher concentrations of the inflammatory cytokines that have direct contact with the cartilage surface and expose chondrocytes to the cytokine environment that accelerates their degradation. Research has documented that knee effusion is a significant predictor of osteoarthritis symptom severity and progression, with larger effusions associated with higher pain scores and faster rates of cartilage volume loss on MRI over follow-up. The fifth most common sign of knee arthritis is reduced range of motion, the loss of the full bending and straightening capacity of the knee that healthy anatomy provides. The normal knee has a range of motion from 0 degrees full extension to approximately 140 degrees of flexion. Osteoarthritis reduces this range through 3 mechanisms: the mechanical obstruction produced by osteophytes, the bone spurs that form at the joint margins and physically limit the range of motion at the extremes of extension and flexion; the capsular contracture, the tightening and thickening of the joint capsule that occurs in response to chronic inflammation and disuse; and the pain inhibition of movement, the protective restriction that the nervous system imposes when movement into certain joint positions produces pain. Research published in the journal Arthritis Research and Therapy documented that loss of knee range of motion, particularly loss of full extension, is one of the strongest functional predictors of future mobility limitation in adults with knee osteoarthritis. The pain pattern of knee osteoarthritis has additional characteristics beyond the 5 primary signs worth describing in detail. The pain is typically a deep, aching discomfort rather than a sharp or stabbing sensation. It is typically located at the joint line, the bony border, where the femur meets the tibia, on the inner side for medial compartment osteoarthritis, the outer side for lateral compartment osteoarthritis, or below and around the kneecap for patellofemoral osteoarthritis. It is typically worsened by weight-bearing activity and relieved by rest in earlier stages, but as disease progresses, rest pain and night pain develop, reflecting the progression from purely mechanical pain generation to the more sustained inflammatory and sensitization-driven pain that characterizes moderate to severe disease. The concept of central sensitization becomes increasingly relevant as knee arthritis pain persists. In adults who have had knee pain for more than 6 months, the pain processing pathways of the central nervous system begin to reorganize around the chronic pain signal, amplifying the peripheral input and generating a pain experience that is disproportionate to the structural changes visible on imaging. This central sensitization is the reason why some adults with relatively mild radiographic changes have severe pain, while others with significant structural changes have surprisingly tolerable symptoms. Recognizing central sensitization specifically, when pain is widespread beyond the knee, when normally non-painful stimuli produce pain, when pain is associated with significant sleep disruption and fatigue, is important because it guides specific treatment additions including duloxetine and pain neuroscience education. That pure peripheral anti-inflammatory treatment cannot address. The imaging dimension of knee arthritis diagnosis, the relationship between what the X-ray shows and what the knee actually feels like, is one that many adults have questions about. The classic radiographic signs of knee osteoarthritis include joint space narrowing, subchondral sclerosis, osteophytes at the joint margins, and subchondral cysts quantified by the Kellgren-Lawrence grading system from grade 1 through grade 4. The crucial clinical point is that radiographic grade correlates only moderately with symptom severity. Many adults with grade 2 or 3 radiographic changes have severe symptoms, while others with grade 3 or 4 changes remain surprisingly functional. The treatment decision should therefore be driven primarily by symptom severity and functional impact, not by the radiographic grade alone. The modifiable risk factors for knee osteoarthritis progression are where the intervention opportunity lies. Excess body weight: with every kilogram of excess weight producing approximately 4 kilograms of additional knee joint loading per step. Quadriceps weakness, the most important local modifiable risk factor, and the one most directly addressed by the exercise program we have described across this series. Previous knee injury, particularly ACL tears, meniscal injuries, and patellar dislocations, which accelerate the osteoarthritis timeline. And the modifiable dietary and nutritional factors: the refined sugar and omega-6 oils that drive systemic inflammation, and the vitamin D and omega-3 deficiencies that impair the joint's anti-inflammatory and cartilage protective mechanisms. Every modifiable risk factor successfully addressed is a measurable contribution to a slower disease trajectory. The functional signs that accompany the 5 primary diagnostic signs: difficulty walking a certain distance before needing to rest, avoidance of stairs by preference, difficulty getting in and out of low chairs or cars, the instability that quadriceps weakness and reduced proprioception produce, and the altered gait pattern that pain and mechanical dysfunction create, are captured in the standardized outcome measures that every adult with knee arthritis should know: the Knee Injury and Osteoarthritis Outcome Score (COOS), the Western Ontario and McMaster University's Osteoarthritis Index (WOMAC), and the Oxford Knee Score. Recording these scores quarterly provides objective evidence of the trajectory that informs both personal awareness and physician assessment of whether current management is adequate. The 5 signs we have described: morning stiffness, activity-related pain, crepitus swelling, and reduced range of motion, are not the inevitable and unmanageable consequences of aging that many adults with knee arthritis have been implicitly led to believe. They are measurable, addressable, evidence-based targets for the interventions that the research has established as genuinely effective interventions that produce better outcomes when applied earlier rather than later, when joint changes are less advanced and the response to treatment is more complete. A physician evaluation that includes weight-bearing X-rays and establishes the Kellgren-Lawrence grade. A comprehensive non-surgical management program, the specific exercise program, the anti-inflammatory dietary changes, the proven arthritis vitamins, the topical diclofenac. Systematic monitoring through validated outcome measures. These 3 actions, initiated at the recognition of the 5 signs rather than years after, represent the most impactful sequence of responses to the clinical information your knee has been providing. Your knee has been telling you something. This video has given you the language to understand what it is saying and the knowledge of what to do with that understanding. The signs are there. The management is available. The decision to act on them is yours. The psychological dimension of receiving a knee arthritis diagnosis or of recognizing in oneself the 5 signs that indicate its likely presence deserves honest acknowledgement in this video, because the emotional response to this recognition is a real and clinically important component of the patient experience that medical guidance frequently neglects. For many adults, recognizing that the morning stiffness, and the stair pain, and the crackling sound are not aging but are specific signs of a named progressive joint condition produces a complex emotional response. Relief that there is an explanation, anxiety about what the future holds, grief for the physical capability that may already have been lost, fear of a trajectory toward the knee replacement that a parent or sibling experienced, and often, a sense of urgency, the feeling that time has already been wasted and that the window for effective management is narrowing. All of these responses are understandable, and the most useful thing this channel can offer in response to them is not reassurance that is not warranted, but accurate information about what the evidence actually shows about the trajectory of knee arthritis when it is appropriately managed, because the accurate information is itself reassuring in ways that false hope is not. Knee osteoarthritis managed with the comprehensive evidence-based program we have described across this channel: the daily exercise, the anti-inflammatory diet, the proven supplementation, the appropriate pharmacological management, the weight management, the sleep optimization is a condition that a significant proportion of patients stabilize rather than progressively worsen. The research on outcomes in adequately managed knee osteoarthritis shows that many patients maintain functional capacity, pain control, and independence for years and decades without surgical intervention. The patients who do best are not necessarily those with the mildest disease at diagnosis. They are those who manage most comprehensively and most consistently after diagnosis. The psychological state of the patient, specifically their pain catastrophizing level, their self-efficacy for managing their condition, their sense of control over their health outcomes, is one of the strongest predictors of functional outcomes in knee osteoarthritis, independent of the radiographic grade or the baseline symptom severity. Adults who understand their condition, who believe in the effectiveness of the management they are implementing, and who maintain an active rather than passive relationship with their care, these are the patients who sustain the management program and achieve the best long-term outcomes. Pain neuroscience education: the systematic provision of accurate information about how pain works, why it is not a perfect readout of tissue damage, how central sensitization amplifies pain beyond what peripheral joint pathology produces, and how the management program addresses multiple dimensions of the disease simultaneously, is not simply educational background. It is a therapeutic intervention that reduces pain catastrophizing, improves self-efficacy, and produces better outcomes from the physical and nutritional interventions applied alongside it. This video and the complete arthritis series on this channel is, in its own way, a form of pain neuroscience education and patient empowerment delivered at scale. The adult who watches this video and understands the 5 signs, their biological basis, their diagnostic significance, and the comprehensive management response they warrant, is a more empowered, more informed, and more therapeutically responsive patient than the one who arrived with the normalizations we described in the opening. That empowerment is the point. Your knee arthritis, recognized early and managed comprehensively, is a condition that you can navigate with far greater effectiveness than the fear of a diagnosis typically suggests. The signs are the starting point, not the ending point, and the management that follows their recognition is where the story that matters gets written. You now have the information. The recognition is yours. The management starts now. The differential diagnosis dimension: understanding what else can cause the 5 signs we have described, and how knee osteoarthritis is distinguished from those other conditions, provides the clinical context that prevents unnecessary alarm and that guides the physician evaluation most effectively. Morning stiffness occurs not only in osteoarthritis and rheumatoid arthritis but in other inflammatory joint conditions including psoriatic arthritis, reactive arthritis, and the spondyloarthropathies, conditions that require different management approaches and whose presence would substantially alter the treatment plan. The duration threshold we described: 30 minutes for osteoarthritis versus more than 30 minutes for rheumatoid arthritis, is a clinically useful but not infallible distinction. And the physician evaluation that assesses the distribution of involved joints, the presence of systemic symptoms like fatigue and fever, inflammatory blood markers like C-reactive protein and rheumatoid factor, and the pattern of X-ray changes provides the definitive picture. Crepitus occurs in healthy knees, particularly the patellofemoral joint produces audible crepitus in many young, healthy adults with no joint pathology, and its presence alone is not diagnostic of osteoarthritis. The clinically significant crepitus is that which is painful, that has developed or worsened recently, or that is accompanied by other signs of joint dysfunction. Painless, long-standing crepitus in an otherwise asymptomatic joint is a reassuring finding rather than a concerning one. Knee swelling can reflect pathology beyond osteoarthritis: a Baker's cyst behind the knee, a meniscal tear producing a reactive effusion, bursitis of the prepatellar or infrapatellar bursa, or in younger adults, inflammatory arthritis conditions that produce joint effusion as a primary manifestation. The location of the swelling intra-articular versus extra-articular, the character of the fluid if it is aspirated for diagnostic purposes, and the associated symptoms and history provide the differentiation that the physician evaluation establishes. Reduced range of motion at the knee can reflect posterior capsule tightness, the most common soft tissue cause of extension loss. Responsive to specific stretching and physical therapy, as well as the osteophyte obstruction and capsular contracture of osteoarthritis. A locked knee. The sudden inability to extend the knee fully that occurs with a displaced meniscal tear is an orthopedic emergency that presents acutely rather than as the gradual range of motion. Loss of osteoarthritis, and its distinction from the gradual stiffening of advancing osteoarthritis is usually straightforward from the history. Activity-related knee pain that worsens with descending stairs and rising from chairs in a middle-aged or older adult is highly suggestive of patellofemoral or tibiofemoral osteoarthritis, but activity-related pain can also reflect patellar tendinopathy, iliotibial band syndrome, or anserine bursitis, conditions that are distinguishable through the specific pain, location on examination, and that respond to treatments different from those most effective for osteoarthritis cartilage pathology. These differential diagnostic considerations are not presented to generate diagnostic uncertainty, they are presented to emphasize the value of the physician evaluation, that the recognition of the 5 signs should prompt. The 5 signs indicate that something is happening in the knee that deserves professional assessment. The physician evaluation provides the specific diagnosis that guides the specific treatment. And the treatment that this channel has documented in detail across the complete arthritis series applies most effectively when it is applied in the context of a confirmed diagnosis with a known Kellgren-Lawrence grade and a known compartment distribution, because the exercise technique modifications, the footwear choices, the injection treatment consideration, and the specific pharmacological approach all vary in their specifics according to these diagnostic details. The conversation to have with your physician after watching this video is therefore not simply "I think I have knee arthritis," but the more specific and more productive conversation, "I have been experiencing morning stiffness that resolves within 30 minutes, pain going downstairs, crepitus that has become more frequent in the past year, and occasional swelling after activity. I would like a formal evaluation including weight-bearing x-rays, a range of motion assessment, and a discussion of the Kellgren-Lawrence grade so that I can begin the appropriate management program." That specificity drawn from the understanding this video has provided is the clinical conversation that produces the most complete evaluation and the most actionable management plan. Knowledge of the 5 signs, understanding of their biological basis, the clinical vocabulary to discuss them accurately, the appropriate response to each one, and the psychological empowerment to approach the diagnosis as a manageable condition rather than an inevitable decline. This is everything this video has been designed to provide, and it is everything you need to begin the journey from the recognition of knee arthritis to the comprehensive management of it. Your knee has been telling you something for a long time. Now you know how to listen and what to do with what you hear. If this video gave you the clear, evidence-based explanation of the 5 most common signs of knee arthritis that you have been looking for, please support this channel. Hit the like button right now. Subscribe if you have not already. Share this video with someone who has been normalizing these signs and has not yet had the conversation with their physician that this video should prompt. And leave a comment below. Tell us which of the 5 signs you recognize in your own knee and how long you have been experiencing it before watching this video. We read every comment. Thank you so much for watching. See you in the next one.